Good afternoon, friends. Welcome to my channel, Pediatric Classes. Today, I'm going to discuss a very important topic that is about the recent NIPAH infection. So, I was just going through the document issued by the Ministry of Health, Government of Kerala. It is a very wonderful document. I thought I'll just have a discussion based on that document. So, let me start sharing my screen. If you're not subscribed to my channel, kindly do subscribe and support the initiative. So, in this session, I'll use the document issued from the Ministry of Health and Family Welfare, Government of Kerala, on 5th September 2021. This document, when you actually see, this is a 64-page document. Yeah, I just taken the salient features out of it, and it also includes all the things, the detail about the treatment and other things. If possible, just kindly go through it. It's a very useful document. I would like to, before the start of the talk, I would like to thank all the officials and all people behind this document. Okay, so let me go into the next thing. So about the agent. Okay. So the agent is Nipah virus. As you all know, it is a pathogenic RNA virus belonging to Paramyxoviridae family. This is grouped under the genus Nipah virus. There are two NIV clades have been proposed, Bangladesh genotype and also the Malaysian genotype. Actually, in the Kerala type, phenotype has almost 86 to 95% similarity to these genotypes. The natural reservoir is the large food bats of Pteropus genus. The intermediate hosts are the pigs. Incubation period varies from 4 to 14 days. The mode of transmission. The human infection occurs from spillover transmission from bats or through human to human transmission. Okay. So direct, what is this bat to human transmission is when the fruits which are contaminated by the bat secretions. The bat secretion can be urine or the saliva. It is consumed by the humans, or if the consumption of raw date palm sap contaminated by the bat saliva, all this can cause a infection in the humans. In the Malaysian outbreak, what has happened is the human infection occurred through contact with the respiratory secretions and urine from the infected pigs. These pigs got infected after consumption of the partially bat-eaten fruits dropped in the pig seed. Okay, so there is always a direct transmission from human to human, also spillover transmission. So this stresses the importance of contact precautions whenever you deal with a patient of Nipah. Coming to the clinical features, the features include fever, altered mental status, severe fatigue, headache, respiratory distress, cough, vomiting, muscle pain, convulsions, diarrhea. See, severe illness is characterized by encephalitis, that is the inflammation of the brain, and also the respiratory distress. All this, when you see this symptomatic syndromic presentation, this will get confused. This has almost a similar presentation like an ARDS, myocarditis, and encephalitis. So we have to have a high index of suspicion for this diagnosis. Patients can present with fever also, or even fever alone also they can present. So what we need to know is the patients coming with fever or without any other symptom, but having an epidemiological link and a history of contact should be treated as NIV infection and must be tested for the NIV infection. So the case fatality rate is around 40 to 75%. However, it may vary by outbreak and can even be up to 100%. The investigations are the real-time RT-PCR viral RNA and also anti-Nipah viral antibodies, that is IgM and IgG antibodies, but enzyme-linked immunosorbent assay. So what samples should we collect? We can collect the throat swab. One thing I want to stress is we have to have extreme good precautions. Whether the person who is collecting the sample should have wearing a proper PPE, proper sterile precaution. They need to take the samples. We need to have a throat swab in the viral transport medium. Have urine around 5 ml in universal sterile container. Blood in a red container. A CS of 1 to 2 ml in a sterile container. Please note the samples should be transported at 2 to 8 degrees Celsius to the concerned labs. So previously it is sent to NIV Pune and now also to NIV field station in Alappuzha, or asked for the testing protocols. So, who should be suspect Nipah? A person, this is the recent guidelines from the September 5 document. As I told you, the whole document has this recent changes and also the previous full document on Nipah. The person from an area or locality affected by a Nipah virus disease outbreak, okay, who has acute fever with no onset of altered mental status or seizure, and or acute fever with severe headache, and or acute fever with cough or shortness of breath. So, in a case of suspect Nipah, just remember if the person is coming from an area affected by Nipah and the person is having CNS symptoms, like for example a headache or a seizure, or just a fever with early headache, or fever with respiratory symptoms like cough or shortness of breath, suspect Nipah. Probable Nipah. Who is probable Nipah? Suspect case of patients who reside in the same village were suspect of confirmed cases Nipah were living during the outbreak period and who died before complete diagnostic specimens could be collected. Or even a suspect patients who come in direct contact with confirmed case patients in the hospital setting during the outbreak period and who died before complete diagnostic specimens are also considered as probable Nipah. So I repeat here, probable Nipah is two categories. One from the same epidemiological area as that of a Nipah case, or even from a hospital where a person is having a contact with a Nipah case, but who has died before a full diagnostic specimen is collected. Those cases are probable Nipah. And confirmed Nipah is a suspect case, but who has a laboratory confirmation of Nipah virus infection either by Nipah viral RNA identified by PCR from throat swab, urine, serum, or CSF optional, or isolation of Nipah virus from throat swab, urine, serum, or the respiratory fluid. So what is understood here is we need to have a laboratory confirmation in a suspect case to say it as a confirmed case of Nipah. The contact tracing will be under the community medicine department and also the DMO team as per the document by the central contact tracing team and by also the field workers. So this is one very good risk stratification of contacts as per the 5th September 2021 document from Government of Kerala. There are two categories. There is the high risk and the low risk. Okay. So what is this high risk? High risk is a person having any contact with the body fluids. So that's why we have to be very careful here. Body fluids. It can be blood, urine, saliva, etc. of a confirmed case of Nipah, or a contact with the body fluids with the probable case who died without a lab confirmation of Nipah, or the patient, the person who has spent time in close proximity or in close place for more than or equal to 12 hours. All these people are taken as high risk. Whereas low risk is any other contact such as touching, contact with the clothes, linen, or any other items used. So in a high risk patient, if it is the high risk contact, if the person is asymptomatic, we can just advise home quarantine with active follow-up for fever by healthcare workers using telephone twice a day for 21 days. I will repeat here, it is the same is for 21 days. Whereas the patient is the contact person is having symptoms, immediate admission to the designated isolation ward with ICU facility. If it is a low risk case, if the patient is asymptomatic, it just requires a home quarantine and follow-up for fever by the healthcare workers over telephone. If the patient is having symptoms, we need immediate admission to the designated isolation facility. So coming to the treatment, so the most important step in patient care is intensive supportive care. It also requires other support like we need to isolate the patient in isolation facility, the proper use of PPEs, the proper use of hand washing technique. Most of the now we are knowing because of the COVID pandemic, but all these things are to be practiced at most sincerely for the proper control of infections. Hand washing with soap and water before and after handling the patients. Resuscitation, ABC if required. Care of the unconscious patient, change of posture, care of the eye, bowel, bladder, etc. If there is a respiratory difficulty, yes, the patient requires how to. Nutritional support is by oral or NG tube feeding according to the condition of the patient. Maintain fluid and electrolyte balance. Please note here, adults, it is 5% DNS which is used, whereas in children, 5% DNS or N/2 or N/4 NS also can be used. Okay. Fluid restriction, 30% restriction, particularly in children. 2/3 of the daily maintenance can be given to children if the child is not in shock. Please maintain an input-output chart, and the bronchodilators are required, which required can be given through spacers, and treat accordingly. So this is the diagnostic algorithm, a little smaller, I think, font, but I didn't want to cut it because it is such a complete document. I request all the viewers to just go back and refer to the 5th September 2021 document by the Government of Kerala. A very beautifully written document and concise also. In the treatment algorithm, let me see. So there is a suspect case with history of definite contact with symptoms. We need to test for NIPAH, that is wet roadstar, blood and urine, and CSF if the symptoms are present if available. If the patient is tested for positive, test positive or a confirmed case, continue intense supportive care. Consider monoclonal antibodies, remdesivir, favorable, ribavirin after discussion with the patient. Treatment plan to be formulated by the institutional medical board. And the patients on monoclonal antibodies, it will be administered only on compassionate ground. The dosage is 20 mg per kg infusion, 2 doses in 48 hours. If the patient is not for maybe we can give remdesivir 200 mg IV followed by 100 mg IV once a day for up to 12 days, or go for favorable 1800 mg twice a day for 1 day followed by 800 mg BD for next 13 days, or you can give a go for ribavirin with 2 grams stat and 1 gram 6-hourly for 1 to 4 days, or 500 mg 6-hourly, that's from 5 to 10 days. Okay, so this is all when you get it. But another thing is, the patient also requires intense supportive care general measures. The symptoms are enteritis, treat the encephalitis, treat the ARDS, and treat the myocarditis. The detailed description is given in the document. And 4th is the post-exposure prophylaxis. Injection remdesivir 200 mg loading followed by 100 mg IV OD for 12 days, or favorable 1800 mg BD for 1 day followed by 800 mg BD for another 13 days. Can be used as for post-exposure prophylaxis also. Now, what is the discharge policy? So we have had the contact with case decision on NIPAH. We are admitted in isolation ward, tested for RT-PCR, and the patient is positive. We are treated as per the guidelines. Discharge when clinically stable. The RT-PCR from all 3 samples. Okay, that is, we have the throat swab, blood, urine negative on 2 occasions, 5 days apart. So that needs to be understood very clearly that we require 3 samples negative on 2 occasions, 5 days apart, to be decided by the treating physicians and confirmed by the medical board. And if it is negative, observe the patient for 3 days. Asymptomatic, you can discharge and observe at home for 21 days. If it is symptomatic, if the patient develops new symptoms, repeat the test. After 2 days, if positive, can treat accordingly and discharge as per the guidelines. If it is negative and the patient is asymptomatic, observe for another 3 days with the last test. And if it is still asymptomatic, you can discharge. If symptoms persist, investigate for alternate diagnosis, shift out of isolation ward, case-based decisions should be taken, and full infection control practices should be undertaken. So these are about the discharge guidelines. So in this session, I have discussed in short about what exactly is a suspect, probable case, confirmed case, etc. What are the investigations you said, and what is the treatment approach in a nutshell. So thank you so much for your patient listening. And if you have not subscribed to my channel, kindly do subscribe. And if you like this channel, please hit the like button and also share with your colleagues for a learning experience. Thank you so much and stay safe.